Hello, my name is Tim German and I'm a spinal neurosurgeon. I have a particular interest in the management and diagnosis of spine-related pain. Over the course of my career, I have become increasingly concerned that current management of people with spine-related pain is irrational and possibly dishonest. What is more, these practices are not confined to the management of spine-related pain, but apply to many aspects of current medical practice. In this talk, I will consider some of the fundamental principles which should underpin medical practice. I will describe how these principles are ignored and show how the medical establishment is complicit in the process. In part 2, I will discuss how and why this can happen. My starting point is to ask the question, what is the point of a doctor of medicine? What are the fundamental skills of a medical doctor? Here's a chap who had a pretty good idea of what that is. This is Hippocrates. And he said, the point of being a doctor is to make a diagnosis. Only then can we have a rational basis for treatment. And interestingly, he also realised that you have to treat the patient in the context of their life. I'm sure he would also have suggested that ideally there should be evidence of efficacy. I think he was fundamentally correct, but I'm going to show that we learn fundamental principles at medical school which are then ignored in day-to-day practice. 2,000 years after Hippocrates, I'm sure we like to think we have made progress and we do have an accepted diagnostic process. The patient complains of a symptom, which in my world of spinal surgery is almost always pain. An appropriately trained individual takes a history and performs an examination. If imaging confirms the presence of a structural abnormality which corresponds with the patient's symptoms, you can then discuss with them the risks and benefits of surgery to try and improve their symptoms. One of the reasons that the life of a spinal surgeon is very fulfilling is that spinal surgery to decompress nerve roots in order to treat pain is extremely effective. Effect size is a statistical technique which you can use to try and compare the magnitude of effect of different interventions. On the left, you can see the change in pain score following surgery for 600 of my consecutive patients, completely unselected. This equates to an effect size of 2.5. An effect size of equal to or greater than 0.8 is considered large. 2.5 is the same as for a total hip replacement. So you can see that decompressing nerves to treat pain is extremely effective and very fulfilling. So, once you have a diagnosis, you can consider specific rational intervention and it can be extremely effective. Without a diagnosis, the best you can expect is placebo. The problem is, in the world of spinal pain, it is common for there to be no diagnosis. But if you have a patient with pain, there clearly is an explanation. So what might that be? What are the possibilities? Well, perhaps a diagnosis has been missed. And I think this is a relatively common experience. In my world, I think a lot of people with nerve root compression, which is potentially causing pain and is potentially amenable to surgery, are not diagnosed or take a long time to achieve a diagnosis. Why this might be the case is the subject of a whole talk of its own. Suffice to say here that if you can make this diagnosis, then you can consider surgery. However, these people are still probably a small minority. So what about the rest? Well, it may be that there's a structural explanation which is as yet undiscovered and does not appear on an MRI scan. There's not too much we can do for such cases other than to strive to improve our understanding of the structural causes of pain. Then we have central sensitization. This is where the patient's perception of pain persists after the painful stimulus has ceased. This condition is probably on the same spectrum as psychiatric or psychological distress causing a perception of pain. And I should say here that it doesn't matter what the source of the pain is, it doesn't make it any more or less distressing or painful. In order to manage the overwhelming numbers of people with low back pain seeking assistance, most countries have published official guidance. In England, the NICE guidance on low back pain and radicular pain has been used to give advice on commissioning services. The objectives of this pathway are to identify serious pathology using red flags, to fast-track treatable specific pathology such as prolapsed disc, and to provide effective and expeditious treatment for non-specific low back pain. All these objectives are problematic. The initial symptom of almost all serious spinal pathology is pain. The identification of red flags in order to determine whether or not the underlying diagnosis is serious is unreliable, as demonstrated in this paper published in the BMJ. How about fast-tracking treatable pathology such as disc prolapse causing nerve root compression? The problem here is that no one agrees on the distribution of pain which can be attributed to nerve root compression. This paper looked at 123 sequential people undergoing nerve root decompression with 20 different surgeons. Only one fulfilled the NICE criteria for pain which could be attributed to nerve root compression. So, had guidelines been adhered to, 122 of the 123 people, all of whom did extremely well following surgery, would not have received an MRI scan, let alone the chance to discuss the risks and benefits of surgery. They would have been labelled with non-specific low back pain. At least they would be entitled to effective and expeditious treatment. The problem is that there is no effective treatment in the absence of a diagnosis. The label may apply to a person with undiagnosed nerve root compression, pathological fracture, or with no structural abnormality at all. And yet, they are all treated the same. Not only does this appear to be economically unsound, but it's possibly dishonest. Trials looking at the efficacy of non-surgical intervention for the management of non-specific low back pain are of very poor quality, but confirm that effect sizes are small. The most effective treatment in this meta-analysis was acupuncture, with an effect size of 0.6, not much greater than you would expect from placebo, and exactly what you would expect for an intervention not based on a diagnosis and therefore without rationale. It's hard to see how sticking needles into someone is going to cure their back pain, especially when you don't know where the back pain is coming from. This effect size is in stark contrast to spinal surgery for nerve root decompression or hip replacement, where there is a very clear specific diagnosis and a very clear rationale. It might not matter if you stick needles into people without a clear rationale. It might not be effective, but it probably causes little harm. However, until relatively recently, it's been acceptable to perform a spinal fusion for non-specific low back pain, as this paper, published in 2005 in the BMJ, demonstrates. Now, a spinal fusion is a very intrusive procedure, and yet there is no consideration of the ethics of performing this on people in the absence of a clear diagnosis. You might find this unbelievable, but national UK guidance still permits fusion for non-specific low back pain as long as it's part of a randomised controlled trial. Now, the point of a trial is to compare the efficacy of treatment against a suitable control or comparator. My question is, how can any intervention be assessed without the underlying diagnosis being clear? The situation is compounded by guidance discouraging imaging. Widely quoted papers suggest that the benefits of imaging the spine are outweighed by the risk. In fact, there is no objective evidence for this. The one controlled trial looking at early imaging, which is associated with better outcomes for those imaged early, is ignored, and none of these publications consider MRI imaging alone, which has no radiation exposure and provides detailed information. Current guidance permits the denervation of facet joints without any necessity for proving a structural abnormality of any particular facet joint. This seems bizarre. It's well known that denervation results in destruction of the denervated joint. This procedure is not performed for other joints, for example the hip, where it's clear that the joint is indeed the source of pain. Would you have your joints denervated with no evidence of a structural abnormality? Now, I find Dylan's lyrics a little bit like Shakespeare in that he has phrases which succinctly capture the human condition. And I think the lyric, "You got unrighteous doctors dealing drugs that'll never cure your ills," describes what's going on in the management of back pain. In my view, imaging of the spine is essential if a diagnosis is to be confirmed. If a potential cause of pain is confirmed, treatment options can be discussed. If the scan is completely normal, then we need to look elsewhere. Either way, the scan has no risk and is helpful. The question then arises as to whether properly investigated unexplained back pain is any different to any other unexplained pain, and whether unexplained pain is different from any other unexplained symptom. Unexplained symptoms are extremely common across all medical disciplines. Treating people without a diagnosis is common. Sometimes collections of unexplained symptoms are given names such as fibromyalgia, ME, or irritable bowel syndrome. And like non-specific low back pain, they are all treated as if they were a diagnosis. According to English guidance for back pain, you are prescribed core therapies and CBT, although exactly what the problem these therapies address is not clear. In fact, there is a considerable body of evidence which suggests that unexplained symptoms share a common etiology, depression being very common. And it's probably not a coincidence that when looking at reasons for benefit claims, back pain is ranked between depression and other poorly defined and mood-related disorders. There are also other causes of social pain which need to be considered but which are poorly understood. Making a diagnosis remains the cornerstone of effective treatment. This paper, looking at people who have been labelled as suffering from fibromyalgia, when subjected to specialist psychiatric assessment, were found to have a high incidence of psychiatric disorders which might be amenable to psychiatric treatment. When viewed from this perspective, I have to question the role of bariatric surgery. Where is the problem in morbidly obese people? Is it rational or ethical to staple a normal stomach? The founding principle of medicine, making a diagnosis, is ignored. It's not a surprise that other principles learned at medical school are also ignored. Of particular relevance in today's environment are the principles of screening. Screening is described on the NHS website as a way of finding out if people are at higher risk of a health problem so that early treatment can be offered. All authorities agree that fairly strict criteria should be met to make sure a proposed screening programme is appropriate. In fact, these criteria have not been strictly met for breast cancer screening, which may explain the observations found in this paper. The criteria are certainly not met for the current screening of asymptomatic people for COVID infection using PCR tests. For example, guidance on the NHS website states that there should be an effective intervention for patients identified through screening. It also states where there is no prospect of benefit for the individual screened, the screening programme should not be further considered. What is more, the UK government's response to the House of Commons Science and Technology Committee report on national health screening states that they agree should be grounded in robust evidence, which is clearly lacking when it comes to PCR testing for COVID infection. So I hope I have shown that the practice of medicine can ignore fundamental principles, leading to irrational, possibly dishonest, and definitely ineffective practices which are sanctioned by the medical establishment. In my next talk, I will explore how and why this might happen. Thank you for listening.